Have you ever wondered why some people suddenly start wheezing or struggling to breathe after a little dust, exercise, or even laughter? Today, we'll explore asthma, its causes, symptoms, and how it can be managed. Asthma is a chronic inflammatory disease of the airways. It is characterized by three main features: reversible airway obstruction, which can improve on its own or after treatment; airway hyperresponsiveness, meaning the bronchi narrow too easily when exposed to triggers; and ongoing inflammation, involving immune cells such as eosinophils, mast cells, and cytokines. If asthma is reversible, what invisible process keeps coming back to narrow the airways again and again? When a person with asthma is exposed to a trigger, such as allergens, infections, or irritants, the immune system becomes activated. This leads to the release of inflammatory chemicals like histamine, leukotrienes, and prostaglandins. The result is tightening of the airway muscles, called bronchoconstriction, excess mucus plugging the small airways, and swelling, or edema, of the airway walls. Over time, repeated inflammation can cause structural changes, known as airway remodeling. Is asthma purely genetic, or can your environment decide whether those genes switch on? Common asthma triggers include allergens like dust mites, pollen, pets, and mold; environmental factors such as air pollution, tobacco smoke, and cold air; viral respiratory infections; occupational exposures to chemicals or fumes. Have you ever heard a high-pitched whistle in someone's chest when they breathe? What does that sound really mean? The hallmark symptoms of asthma are wheezing, especially during exhalation; shortness of breath, chest tightness, and coughing, often worse at night or early morning. These episodes are intermittent, and can worsen after exercise or exposure to allergens. On examination, we may hear expiratory wheezes, notice prolonged expiration, and in severe attacks, the use of accessory breathing muscles. Why does asthma in a child with allergies look different from asthma in an adult who never had allergies before? Asthma comes in different forms: allergic, or extrinsic asthma, which is IgE-mediated and usually begins in childhood; non-allergic, or intrinsic asthma, often starting in adulthood; exercise-induced bronchoconstriction, occupational asthma from workplace exposures; and drug-induced asthma, triggered by medications such as aspirin, NSAIDs, or beta blockers. If wheezing and coughing can happen in many diseases, how do doctors know for sure it's asthma? Diagnosis is based on history and physical features. Spirometry often shows a reduced FEV1 to FVC ratio, with significant improvement after a bronchodilator. Peak flow monitoring can reveal variability during the day. Allergy tests may confirm triggers, and other causes like COPD or heart failure must be ruled out. Spirometry, asthma typically shows an obstructive pattern, a reduced FEV1 and a low FEV1 to FVC ratio. The hallmark feature is reversibility. After using a bronchodilator, the FEV1 improves significantly, often by more than 12% and at least 200 milliliters. This improvement confirms the diagnosis of asthma and distinguishes it from chronic obstructive pulmonary disease. If uncontrolled, asthma can lead to status asthmaticus, a severe and life-threatening attack; respiratory failure with low oxygen and high carbon dioxide; rare complications like pneumothorax; and long-term airway remodeling, which may cause permanent obstruction. Why do some inhalers give instant relief, while others work silently in the background to prevent attacks? Breathing, circulation, ABC. Look for red flags: inability to speak full sentences, cyanosis, silent chest, altered consciousness. Small diamond 2. Immediate interventions: high flow oxygen, maintain SPO above 94%. Short-acting beta agonist, SABA, salbutamol via nebulizer or inhaler, repeated every 20 minutes in the first hour if needed. Ipratropium bromide, add in moderate to severe attacks, combined with salbutamol. Small diamond 3. Corticosteroids, systemic steroids, oral prednisolone or IV hydrocortisone, reduce inflammation and prevent relapse. Small diamond 4. Adjunctive therapies, IV magnesium sulfate, for severe or life-threatening asthma not responding to initial treatment. IV aminophyline or subcutaneous epinephrine in refractory cases, specialist use. Small diamond 5. Monitoring and support. Continuous monitoring of oxygen saturation, respiratory effort, and heart rate. ABG analysis if patient is not improving or deteriorating. ICU transfer if signs of impending respiratory failure, rising CO, exhaustion, altered mental status. Long-term control. For long-term management, a stepwise approach is recommended. At the mildest stage, patients use a short-acting inhaler only when needed. With increasing severity, inhaled corticosteroids, long-acting bronchodilators, and leukotriene antagonists are added. In the most severe cases, biologic therapies like omalizumab or mepolizumab may be used. Patient education is crucial. Correct inhaler technique, adherence to medications, and a personalized asthma action plan are all vital. Could avoiding a dusty room, a cigarette, or even skipping your flu shot decide whether you end up in the hospital or stay safe at home? Lifestyle adjustments play a big role. Patients should avoid known allergens and smoking, maintain a healthy weight, keep up to date with flu and pneumonia vaccines, and exercise regularly, using preventive medication if needed. Upward trend 10. Prognosis. With proper treatment, most patients achieve excellent control and live normal, active lives. Some may develop persistent asthma with structural airway changes, but many children with mild asthma improve as they grow older. Asthma is a chronic inflammatory disease of the airways. It presents with episodic wheeze, cough, chest tightness, and shortness of breath. The hallmark is reversible airway obstruction, confirmed by spirometry with improvement after a bronchodilator. Triggers include allergens, infections, smoke, cold air, exercise, and genetic predisposition. Management is twofold. Acute attacks require oxygen, bronchodilators, and corticosteroids. Long-term control relies on inhaled corticosteroids, bronchodilators, and lifestyle measures. With proper treatment, education, and avoidance of triggers, patients with asthma can lead normal, active lives.